Faculty for inviting me to deliver this lecture on a topic that is very familiar to me clinically and in the research forums as well. So my topic today is non-alcoholic fatty liver disease, NAFL, what's new. I'll highlight in the next 30 minutes how we approach NAFL in 2021. The existing definition of non-alcoholic fatty liver is based on the presence of excess liver fat is more than 5%, detected most commonly on imaging, usually in ultrasound and very rarely on histology, in the absence of any secondary cause. And this definition is very heavy on excluding the secondary cause. The major one that is highlighted here is the absence of unsafe alcohol intake. So the patient should be not taking unsafe alcohol. In other words, should be taking safe or no alcohol. The cutoffs that are relevant to our population, Asian population, is less than 14 units per week for males and less than 7 units for females. We should also inquire about drugs that can cause liver fat, hepatic steatosis like steroids, chronic viral hepatitis, especially hepatitis C, which is well known to cause fatty liver in the early stages, and some hereditary liver diseases like Wilson's. So this existing definition needs the demonstration of excess liver fat more than 5% and the absence of alcohol mainly, because as the term implies, we are mostly concentrating on non-alcoholic fatty liver disease. It's a spectrum of disease and it's a dynamic process. The simplest form of this disease is simple steatosis, or what we also call non-alcoholic fatty liver. There is fat deposition with mild inflammation but never fibrosis. That is the earliest form. In the community, when we see a report with fatty liver, 75% of the patients will belong to this simplest form of the disease. That is simple steatosis or non-alcoholic fatty liver. Then the rest of the patients, about 20%, one-fourth of the patients will belong to a more aggressive form of the disease, that is non-alcoholic steatohepatitis. Here, apart from fat deposition, there is inflammation and hepatocellular injury with some degree of fibrosis. The difference between the simple steatosis and NASH is that NASH, there is inflammation, hepatocyte injury, and fibrosis. Long-standing NASH can progress to NASH cirrhosis with rigid fibrosis, nodule formation, and the usual pathology of cirrhosis. Now, simple steatosis in about 45% of the patients can progress to NASH. And out of the NASH patients, about 20%, one-fifth, will progress to cirrhosis. But more recent literature have shown us that there can be bypassing of this process where simple steatosis can progress rapidly to cirrhosis. We have come across this kind of patients, and it's important to identify these patients because the progression usually takes about 15, 20, 25 years. These patients, it takes only 5 to 10 years. Coming to the pathophysiology, although non-alcoholic fatty liver disease, we are concentrating more on the liver, the pathogenesis involves many organs. Insulin resistance and hyperinsulinemia is central in the pathophysiology. There is insulin resistance in the muscles, the adipose tissue, as well as within the liver. Within the liver, when there is insulin resistance, there is increased gluconeogenesis, there is exaggerated lipogenesis, inflammation, and fibrosis. And when it's the insulin resistance in the adipose tissue will result in lipolysis, increased free fatty acids, inflammation, release of abnormal adipokines, which when taken into the liver will stimulate inflammation and liver fibrosis. And now we know from more recent studies that a leaky gut, bacterial translocation, dysbiosis, that is abnormal gut microbiome, will result in release of inflammatory mediators like TNF-alpha into the portal circulation. It will be carried to the liver, and that will propagate the NAFL process within the liver. And this leaky gut and dysbiosis is heavily influenced by neurohormonal mechanisms Patients who have NAFLD, they usually have abnormal satiety, they have abnormal preferences and appetite. There is overnutrition, especially with regards to fructose and sucrose. Sugar is one of the major drivers of fatty liver disease worldwide. So much so that there is a term called fructoholism, emphasizing that from a very young age, if this unhealthy food is allowed to be consumed by children, that goes into the adulthood as well, and they will keep on consuming high sugary foods and will lead to fatty liver. We also know from studies that certain genetic variants are important in the pathogenesis, and usually the ones that are identified are single nucleotide polymorphisms. There are 3 that are important: PNPLA3, MBOT7, and TMFSF2, are common to both non-alcoholic and alcoholic fatty liver disease. The presence of these variants will result in increased liver damage that is proportional to the steatosis severity. And the diagram in the right lower corner will show that one of the most highly significant that are related to non-alcoholic fatty liver disease, that is PNPLA3, not only increases the risk of NASH and cirrhosis, but causes a 10 times more relative risk of liver cancer and liver-related deaths. The most recent area of interest with regards to the pathogenesis is the gut microbiome. When there is dysbiosis, what we mean by dysbiosis is that the normal variability of the gut microbiome is lost. In a normal person, there is a lot of variation, a lot of organisms, a lot of types of bacteria there. In dysbiosis, this variability is narrowed, less variable, and the helpful bacteria are reduced, like the firmicutes. The harmful bacteria, like the proteobacteria and the E. coli, are increased. And this dysbiosis within the gut will result in increased short-chain fatty acids, reduced choline, and increased endogenous alcohol, which will be carried along the portal vein into the liver, which will stimulate steatosis, steatohepatitis, and cirrhosis. And this endotoxemia will also stimulate Kupffer cells and stellate cells within the liver, stimulating toll-like receptors 4 and 9, resulting in increasing intrahepatic TNF-alpha levels. It will also result in further inflammation and damage. So that is with regard to the pathogenesis. Microbiome is also important because it gives us a signature for the patients who are more severely affected in this disease. When compared to simple steatosis, those who have advanced fibrosis will have an abnormal dysbiosis microbiome signature in the stool. So this probably will be useful in identifying patients non-invasively. So to see which patients have fibrosis in the future, we might collect a stool sample and do microbiome studies to identify those who have fibrosis. So it's turning out to be a signal or signature of advanced disease as well. Coming to the epidemic, it's endemic in all parts of the world. It's a global epidemic. Worldwide prevalence is about 25%. So 1/4 of the adult population is affected by NAFL. Interestingly, this will be double in those with diabetes. Prevalence of NAFL among diabetes is about 56%. NASH, it's about 1/5. In the general population, the prevalence is about 5%. But among the diabetics, it's more than 7 times. So NASH is more common in diabetics. Now in fatty liver, it's about twice, 25% in the general population, but in diabetics, fatty liver is 55%. But when it comes to the more aggressive disease, in the general population, the aggressive disease is only about 5%, whereas in diabetics, it's 37%, 7 times. Having diabetes is bad for NASH. In our studies, we know that the prevalence among Sri Lankans is about 32%, and the annual incidence is about 6%. From studies done here in Ragama, we can sort of extrapolate this data to the Sri Lankan urban adult population. What are the risk factors? There are modifiable or dynamic risk factors and non-modifiable static risk factors. The modifiable risk factors are strongly associated with the metabolic syndrome, insulin resistance, pre-diabetes, diabetes, dyslipidemia, hypertension, general and central obesity, poor diet, lack of exercise, and sleep apnea is also associated. The non-modifiable ones are gender, increasing age, the genetics, which I have already talked about, some endocrine factors, and ethnicity. We know that from studies, Asians and Hispanics have more NAFL compared to Caucasians and Africans. When we look at morbidly obese patients presenting for general surgery, so bariatric surgery, we know that 90% of them will have NAFL. And among general obese patients and diabetics, the prevalence of NAFL is as high as among patients with metabolic syndrome and dyslipidemia, it's about 50%. So having NAFL will also result in future development of non-communicable diseases. There is a 2 to 5 risk of developing future diabetes, about 2 times risk of developing heart disease and kidney disease, 2 times of developing. So there is a strong association of metabolic risk factors or metabolic dysfunction with fatty liver. But unfortunately, the present definition does not reflect this at all, because the non-alcoholic fatty liver disease term just says demonstrate fatty liver and exclude alcohol. There is no talk of metabolic association. So there is a suggestion that this NAFL term should be replaced with something that is more reflective of the strong metabolic associations, and that a term is called metabolic dysfunction associated fatty liver disease, or MAFLD. Now, this is the proposed definition. So first of all, just as in NAFLD, we have to demonstrate excess liver fat, either by imaging, biomarkers, or histology. And if the patient is either overweight or obese or diabetes, they straight away fulfill the criteria, can be called MAFLD. But there will be a group of patients who are lean, non-obese, non-overweight, and those who don't have diabetes, that is the central one. And those individuals, we should keep on looking for other minor metabolic risk factors like increased waist circumference, raised blood pressure, high triglycerides, low HDL, pre-diabetes, insulin resistance, and persistent elevated CRP. If 2 or more of the minor criteria are present, still we can diagnose MAFLD. Now, is this important? Here is a study that we have published. It probably will come online in 1 or 2 days from now. We did a prospective study involving more than 3,000 patients, followed up for 7 years. At baseline, we applied the NAFLD and MAFLD criteria and looked at what happened to them. And when we compared NAFLD and MAFLD, MAFLD seemed to capture a little bit more than NAFLD. So it's a little bit more inclusive, but you can see there is a huge overlap between the 2 definitions. 2 definitions are broadly very similar. So NAFLD is not so bad, but MAFLD seems to be doing. And NAFLD and MAFLD had similar metabolic traits at baseline. They had equal diabetes, equal obesity, equal hypertension, equal dyslipidemia. But the important thing is that those who were excluded by NAFLD but included by MAFLD did poorly after 7 years. So those are the outliers. So the people who were missed by the NAFLD definition but was caught by the MAFLD, they did poorly. So it's important that we do not miss these patients, because if we intervene and correct their metabolic traits, we prevent cardiovascular death and outcome. Therefore, we feel that MAFLD seems to improve clinical utility when applied to the population, community population like ours. Coming to the outcomes, The presence of metabolic syndrome increases the overall mortality of NAFL. One or more of the criteria of the metabolic syndrome, as you can see in this graph, will reduce survival. In a study done in our setting, we also found that the presence of metabolic syndrome in NAFL independently was associated with increased all-cause and cardiovascular mortality. And when we compare simple steatosis to NASH, there is about 5 times increased mortality in NASH compared to simple steatosis. That's expected because in simple steatosis, there is no liver injury. And it's important to know that the majority of these patients will die of cardiovascular disease, liver-related disease. If you take the second most commonest cause of death, it is still cancer. Breast cancer in females and colon cancer in males. And only the third commonest cause of death is liver-related. So when you identify these patients with fatty liver, we should pay careful attention to the metabolic risk factors and correct them, because mostly these patients die of heart disease rather than the liver disease itself. So we have shown that NASH is worse than simple steatosis, but what is most worse for outcomes is the presence of fibrosis. Significant fibrosis, which is defined as F2 or more, as you can see in this graph on the left, significant proportion of patients die when they have fibrosis at diagnosis. Liver fibrosis is the strongest predictor of mortality in fatty liver disease. How do we stage this disease? So it's important to identify simple steatosis from NASH. It's also important to identify those who have liver fibrosis. So if we only go by the biochemistry in this landmark study involving about 2,300 patients, 1/3 had NAFLD. That is roughly similar to our population, where we had 30 patients with fatty liver. Only 1/5 will have abnormal liver biochemistry. So we can't go only by the liver biochemistry, because there can be patients with fatty liver who have normal liver biochemistry. And if you go by the weight, it's also important. We think fatty liver patients are overweight patients, but look at this graph, the study on the right side. Only half of the patients were obese, and 1/4 of them were overweight, and 1/5 of them were actually lean, meaning that they were not even overweight. They had normal BMI. So a study done by us also showed that 21% of our population are also lean NAFL patients. So we should be extra vigilant in not missing these patients, because they also have the same poor outcome. So if we go by routine imaging alone, that is well known to be inadequate. Ultrasound is a little bit better than CT, because ultrasound, the definition cutoff of 5% will only catch 2/3 of the patients. The best radiographers looking at doing ultrasounds will catch only 2/3 of the patients if they have liver fat around 5 to 10%. If it's more than 20%, they will be able to identify most of the patients, 90%. But these percentages are much less in CT. That is because CT, you are looking through films. Cross-sectional imaging, it's not real time. Whereas ultrasound is real time, bit better. But still, this is not adequate screening, because most of the patients are missed. We now have a tendency to do some serological studies, because that is helpful to identify those who have fibrosis. And 2 scores we routinely use are FIB4 and NAFL fibrosis score, or NFS. The FIB4 has age, platelets, AST and ALT, and using a smartphone application, we can input this data and get a value. If it is less than 1.3, that has a very high negative predictive value, meaning that there is very low risk of presence of fibrosis. So FIB less than 1.3 will rule out significant fibrosis. Whereas if the FIB score is more than 3.25, there is 80% positive predictive value, and that signifies that there is advanced liver fibrosis. That rules in significant liver fibrosis in these patients. In between value is indeterminate, and we will need additional testing. Similarly, for the NAFL fibrosis score, the cutoffs are ruled out. It's less than minus 1.4455, and to rule in, the value is more than 0.676. So once we have the serological assessment, we tend to go on to imaging-based modalities to assess the liver fibrosis. And there are three methods. One is vibration-controlled transient elastography, or VCTE. The more used term is FibroScan. The other one is shear wave elastography, and the best is MR elastography. Obviously, we can't be doing MRI on all these patients. So the point of care assessment, imaging assessment of liver fibrosis is by FibroScan. That is the most widely used. It is very reliable to exclude advanced fibrosis. We commonly use this. If we apply this assessment followed by image-based assessment, we get a two-step assessment of liver. The patient is suspected to have NAFLD. In the primary healthcare setting, we will either do the FIB4 or NSF. And if they are low, they don't have significant fibrosis, they can be managed at the GP level. If they are indeterminate or high risk, we will apply the second line imaging-based fibrosis assessment in a referral center like ours, and we will do a FibroScan to rule in or rule out significant fibrosis. If we rule out, then again they can be low risk and managed. If they are high risk, they will go into specialist management and maybe even liver biopsy. The LSM cutoffs here quoted are a little bit controversial. Okay. So we have this two-step assessment, first serological, then image-based FibroScan, and decide on the treatment. So when will we consider a liver biopsy? Now, liver biopsy is very rarely done for non-alcoholic fatty liver disease. When I was a trainee, we used to do a lot of biopsies because of this non-invasive assessment of liver fibrosis now that is available. We are moving away from doing too much biopsies. We will do biopsies only for patients who have repeated indeterminate values both on the serology and the FibroScan. And if we think that there is a secondary cause of fatty liver, the patient strongly, either due to some abnormal serology or biochemistry or viral serology, that has come as positive, or there is an unusual family history, or the patients who do not improve despite lifestyle changes once treatment is initiated. So those are some of the rare, less common indications for liver biopsy. So last part is the current management of NAFL. So as I said, these patients die of cardiovascular disease. So the most important component of management is management of the cardiometabolic factors. And we should not forget the oncological management, because these patients should have appropriate cancer screening, age and gender appropriate cancer screening. The liver management is actually a minor part in these patients. So these patients are ideally managed in a multidisciplinary team. And who will be in this team? GI hepatologist will be there, internal medicine physician, and endocrinologist, cardiologist, nutritionists, behavioral specialists, and various other people to get these patients to adhere and maintain lifestyle modification and reach the lifestyle targets is the most important management step in these patients. And we know from studies that the patients who are managed in these MDT clinics actually do much better than the general management in a medical clinic. Specialist clinics maintaining a specialist clinic will be beneficial for these patients, and we do have that kind of clinic in our setting. The cornerstone of management, the most important aspect of management of NAFLD is still non-pharmacological lifestyle modification, because all the pharmacological agents that have been tried and tested have been relatively unsuccessful and disappointing. What we are left with is mainly lifestyle modification. And weight loss is the most important thing. If your patient has fatty liver disease, weight loss is the ultimate treatment. They are able to achieve a certain weight loss and maintain that weight loss, their livers will be fine and their outcomes will be. So if we consider the amount of weight loss that is required, about 5% of weight loss will get rid of the liver fat. 7% of weight loss will get rid of the inflammation and resolution of NASH. About 10% weight loss more will even get rid of the early fibrosis. So the outcome of weight loss is so strong that it will also reverse early fibrosis. Okay, and this evidence comes from a landmark paper in 2015 by Vela Gomez, where he looked at 261 patients with NASH, biopsy proven, and applied the lifestyle modification over 1 year period. The study was done in a setting which is very similar to us in Cuba. Simple study, highly quoted, very important, because it clearly showed that you just have to ask your patients to lose weight. What is the problem? We know from our patient experience that those who majority don't lose weight when you follow them up. Very difficult for our patients to lose weight as they are motivated. And out of those who lose weight, maintaining that for even 1 year, only less than 10% did that in this study. So we know what to do for these patients, but we don't know how to get them there and keep them there. That's the problem. So lifestyle modification is the best treatment for fatty liver disease, but it is very difficult to get them to reach the weight targets and ask the patients to maintain that weight targets long term. That's the problem. What about bariatric therapies, which are well known to reach higher weight loss targets, and are more sustainable? At present, we cannot recommend bariatric surgery for NASH itself, but these patients have other problems like diabetes and other risk factors. So if they have the risk factors or indications for bariatric surgery, like high BMI, more than 40 or more than 35 with multiple metabolic risk factors, if they qualify and if they have NASH, yes, certainly refer them for bariatric surgery, because the bariatric surgery will clearly improve the NASH in these patients. But as a sole indication, bariatric surgery is still not included in the guideline. Then we have the liver-directed therapies. There are multiple potential therapeutic targets, which can be either metabolic, anti-inflammatory, or antifibrotic. I won't go through this busy slide, the targets. What I can say is that most of these drugs can be only given to patients who are biopsy proven. They can be given only for a short term, because the trials have been only done for periods of 1 to 2 years, and they have shown some promise in reversing histology. We don't know what the clinical outcomes are. And out of these agents, one agent, Obeticholic acid, is showing some promise. From previous studies, we know from the PIVENS trial and the TONIC trial that pioglitazone and vitamin E reverses, improves histology and improves outcome in NASH patients. So we can give vitamin E to our patients who do not achieve the lifestyle targets, or who are unable to maintain the lifestyle targets, or for a period to allow the patient to get used to the lifestyle targets. So these agents can be given short term, like period of 2 years if they have severe NASH and if they have fibrosis, to allow the patient to get used to the lifestyle. We give them less than 2 years. For example, vitamin E, in your prescribing, you have to be careful because in males, it is associated with prostate cancer. So if you are giving to people who are older males, you have to be careful. Females of reproductive age group, you must advise them on contraception. And vitamin E increases the risk of hemorrhagic strokes in patients. You have to give high doses, 400 national units BD. It's quite a high dose associated with hemorrhagic strokes also. So you have to explain the risks and benefit of taking this and tell the patient this is for short term until you get used to your lifestyle and achieve your weight loss targets, and we will remove the vitamin E once you reach those. Pioglitazone, of course, if the patient is diabetic, you might include pioglitazone in their anti-diabetic treatment. Liraglutide has shown some promise, but metformin has no effect on NASH. Please don't prescribe metformin for NASH, and also for statins. Statins will not improve the patient's NASH. But on the other hand, it is quite safe to prescribe statins in the presence of NASH. If the patient's liver enzymes are elevated and the bilirubin is normal, let's say the enzymes are around hundreds, there is no worry in prescribing a statin standard dose as long as the patient is tolerating. NASH is, these statins are quite safe. If there is another indication like dyslipidemia, to treat it, but don't use statins per se to treat NASH. That is clear. So this is the most recent study, the Regenerate study with use of obeticholic acid, 25 milligrams, again very high dose, biopsy proven, it improved fibrosis, it improved the overall histology, but there was a prominent side effect, that is pruritus, that occurred in about 50% of the patients. There was a lot of discontinuation, and we are still awaiting the clinical outcomes, and this is only histological based outcomes. We don't know what happens long term when you give obeticholic acid, whether it helps these patients, whether it improves survival or not. So in summary, NAFLD is in fact a big problem. It's a global epidemic. We now know that fibrosis is the main predictor of bad outcomes, and MAFLD is proposed as a better descriptor of the disease. Now, when we manage these patients, we adopt a two-step approach, triage these patients to see which patients need specialty clinic follow-up and biopsy, especially when the results are discrepant and require confirmation. And we know that FibroScan is best to rule out advanced fibrosis because it's point of care, it's very simple, non-invasive. And these NAFL patients, NASH patients should ideally be managed in a multidisciplinary team clinics with multidisciplinary inputs. Management of cardiovascular comorbidities should be given the priority in managing these patients. They should be aggressively search for the presence of metabolic traits, and they should be addressed to prevent the cardiovascular outcomes. Lifestyle modification to achieve target weight loss remains the cornerstone of management. Bariatric surgery cannot be recommended at present as sole indication for treatment of NASH. Vitamin E, pioglitazone, and obeticholic acid can be used as liver-directed therapy in very selected patients, when they can be used and for how long. Future therapies are in development and show promise, but still they are not ready for general use. So, thank you. And if you have any questions, or you can direct your questions to my email or Twitter. I think that's better. I think we have run out of time. Thank you.
Thank you, Madunil, for the fantastic talk. And even if you have questions, I'm sure he's happy to answer one or two questions. Any questions from the virtual listeners?
1 diabetes pathophysiology is a little bit different than type 2 diabetes. Almost all the studies have been done linking NAFL to type 2 diabetes, because I showed in the diagram that insulin resistance rather than insulin deficiency is associated with NAFL. Long-term type 1 diabetes 2 is associated with liver fat accumulation, but the pathophysiology is a little bit different. So it is associated, but not as much as type 2 diabetes.
Any benefits with NAFL?
Yes.
Not at the moment.
Actually, I'm not really sure.
Right. So, in the absence of questions, we will wind up the meeting. Anyway, we'd like to thank